A very important topic, not often spoken of to you. It will be very crucial in life as well as in the exam. We have seen chronic kidney disease last time. We are going to do a look at the acute kidney disease. So, acute kidney injury, also called AKI, a modern diagnostic blueprint, definition, etiology, and pathogenesis we will be looking at. The first part. It's on three parts. Part one is the definition, classification, etiology, and pathogenesis. Now, there are four pillars of AKI. This is in an executive summary of the talk. One, the definition. Two, the classification. Three, the etiology. And four, the pathogenesis. What is the definition? An abrupt loss of renal function or structural damage occurring within 7 days. The duration should not be more than 7 days. Either renal functional impairment or structural damage within 7 days. Moving beyond simple filtration markers to include real-time cellular stress. Classification graded via the updated KDIGO, Kidney Diseases Interventions Outcomes Trial, Improvement Global Outcomes Trial, KDIGO staging system, stage 1 to 3, now utilizing a multi-dimensional matrix of serum creatinine, urine output, and biomarker, CUB. When I say C, it is serum creatinine, U, urine output, B, biomarkers. Etiology, it is a multifactorial syndrome driven by collision of latent patient susceptibilities like age, CKD, and acute environmental exposure like sepsis or toxins. So etiology is multifactorial. On the one hand, you have the susceptibility. On the other hand, you have the environmental exposure. What is the definition now? Any renal shutdown, abrupt loss of renal function, or structural damage occurring within 7 days. It is not just only the structural or functional damage, the biomarkers are also important. While classifying it, we take into consideration three aspects: the creatinine, serum creatinine, the urea, urine output, and the biomarkers. Etiology, it is multifactorial, latent susceptibilities, plus the environmental exposure of sepsis and toxins. Pathogenesis, it is a complex interplay of inflammation, dysregulated hemodynamics, oxidative stress, direct tubular toxicity, outdating the simplistic pre-renal, post-renal anatomical models. Earlier, maybe around 10 years before, when I was talking on this subject, I used to classify the acute kidney injury as pre-renal, post-renal, and renal, like that. Today, that classification is outdated. We don't use that terminology. Here, it is a complexity of inflammation is there, dysregulated hemodynamics, oxidative stress, direct tubular toxicity. There is a paradigm shift in the understanding of AKI. This is a 2026 guidelines presentation this month. So, in the anatomical architecture of kidney injury is zone 1, that is before the kidney, the pumping is there, pumps and pipes. Zone 2, the intrinsic filter or the intrinsic filter is there. You can remove that light also.
The light was reflecting exactly on this.
Intrinsic filter is there, that is the kidney, and ultimately the post-renal. Decreased renal perfusion without structural damage. Drivers are hypovolemia, heart failure, systemic sepsis. Significance accounts for 60% of all cases of AKI. Second one, direct structural damage to the parenchyma. Drivers are acute tubular necrosis, glomerulonephritis, interstitial nephritis, nephrotoxins. And zone 3, you have the post-renal mechanical obstruction to the urinary outflow. Drivers are BPH, caliculi, malignancy. This is how we used to understand AKI into 3 zones. One is zone 1, pre-renal, hypovolemia, decreased renal perfusion, heart failure, sepsis, 60%. Second one, intrinsic renal disease, ATN, GN, interstitial nephritis, nephrotoxins. Finally, post-renal, some obstruction either to the bladder neck or urethra or in the ureter, obstructive urinary disease, either due to BPH or calculi or malignancy. It is still, the pathogenesis holds good, but the treatment we are not going to classify like that. Now you see, the past acute renal failure viewed as a binary end-stage clinical event. Earlier we used to have, health and failure. Two components are there. Either he is healthy or he is in failure, one of the two binary classification. Driven by always, AKI means dialysis. Expecting high mortality and dialysis intervention often occurs very late. Now, today, we are now changing with the changing paradigm. This is viewed as a dynamic event, potentially reversible spectrum of structural and functional damage. Early detection, cellular injury is important, systemic hemodynamic optimization is help. Driven by early detection, cellular injury mitigation, and systemic hemodynamic optimization. Okay. Now, see, this is the most important thing. C for the creatinine, U for the urine output, structural damage by the biomarkers. What is the cutoff point? Serum creatinine of more than 0.3 milligrams increase in 24 hours. If it is, let's say 0.7 earlier, now add 0.3, it has become 1. 1 has become 1.3 or 1.2 has become 1.5. Any increase of more than 0.3 milligrams in 48 hours. B, an increase of 1.5 times the baseline. Either one of them is okay. His 1.5 times the baseline is 7 days. More than 3.3 milligrams is 48 hours. That is the first criterion. What is the first criterion? Serum creatinine increase of more than 0.3 in 48 hours or 1.5 times the baseline in 7 days. Urine output. Mean urine volume half ml or less per hour for 26 hours. That means in 6 hours, 1 ml per kilogram per hour. Let's say a patient is 60 kilograms. In an hour, we expect 60 ml. Half of that is 30 ml per hour. If you are not getting in 30 ml per hour in 6 hours, for 6 hours continuously, it means there is a decreased urinary output. These are a diagnostic equation. And structural damage, elevation of validated kidney damage biomarkers. What are those biomarkers? I will show you those biomarkers within the previous 7 days. Now, 3 things are involved. Serum creatinine, the cutoff values, urine output, 0.5 ml per kilogram per hour for 6 hours, creatinine increase of 0.3 in 48 hours or 1.5 times in 7 days, and elevated biomarkers in the last 7 days. These are the various criteria we use. Same thing in the KDIGO matrix we have used. The matrix quantification. Stage 1, serum creatinine increase 1.5 to 1.9 times baseline, urine output less than 0.5. Stage 2, more than 2 to 2.59 times the baseline, less than 0.5 ml for 12 hours. Stage 3, more than 3 times the baseline or 4 milligrams creatinine or more, and initiation of renal replacement therapy or urine output less than 0.3 for 24 hours. This is or anuria for 12 hours. This is to classify the clinical decline. This framework forces early intervention before transient hypoperfusion becomes irreversible structural necrosis. What will happen if the hypoperfusion persists for a long time? It will lead to tubular necrosis and structural necrosis. We have to prevent that. Now you see here the functional criteria and structural criteria. Functional criteria are trailing indicators and structural criteria are the early warning. Markers, serum creatinine and urine output. Limitations, serum creatinine change occurs later, confounded by muscle mass, age, fluid overload. Urine output is easily manipulated by diuretics. Oliguria may be a physiological adjustment. What are the markers? KIM1, NGAL, TIMP2, IGFBP7, KK3. These markers have to be obtained in all patients of suspected AKI. KIM1, NGAL, TIMP2, IGFBP7 and DKK3. What are these abbreviations, expansions? I will give you in your WhatsApp. Advantage. Detects cellular stress and damage or inflammation in real time. Identifies subclinical AKI even if the glomerular filtration remains entirely normal. That means GFR is normal, creatinine not elevated, urine output is not decreased, but these can pick up very early disease, the structural markers. The structural damage precedes functional loss. Okay, what are the four quadrants we have? Transient AKI, a reduction in the function in the form of serum creatinine rise, cystatin C increase, or urinary output decrease lasting for less than 48 hours. That's why it is transient. Persistent means same thing occurring more than 48 hours up to 7 days. Okay, what is the mechanism for transient? Often caused by reduced kidney perfusion, rapidly restores to baseline upon correction of the volume status and removal of the hemodynamic medication. And then in persistent AKI, strongly associated with a higher incidence of progressing to chronic kidney disease and high mortality. 0 hours to 7 hours. That is the timeline. 48-hour mark is the cutoff. If the renal failure is progressing beyond 48 hours, then you call it as persistent. Otherwise, you call it as transient. That is this one. Now you see. Zone 1, 0 to 7 days, it is called AKI. 7 to 90 days, renal impairment, acute kidney disease. More than 90 days, chronic kidney disease. Now what happened? The spectrum is the same. It is the duration only that is important. Abrupt structural damage and functional loss is AKI, and zone 2 is 7 to 19 days acute kidney disease. It is the subacute phase. Criteria are GFR less than 60 or serum creatinine more than 50% increase in the structural damage. AKD can exist without prior AKI also. That means there need not be the first 0-7 days phase. Directly patient can land in acute kidney disease. Structural damage not meeting the 7-day threshold. Zone 3, permanent alteration is a function of structure persisting beyond 3 months. 3 months is the cutoff point for the zone 3. Now, stage 1, stage 2, stage 3. Already I have tabulated there. Serum creatinine 1.5 to 1.9 times, urine output less than 0.5 for 6 to 12. Stage 2, 2 to 2.59 times baseline, and urine output is less than 0.5 but more than 12 hours. Stage 3, serum creatinine more than 3 times or more than 4 milligrams of creatinine or RRT is initiated. Urine output, of course, is less than 0.3 ml per kilogram per hour, persisted for 24 hours, or patient is in anuria. So patients are staged between 1 to 3 according to the worst criteria met by serum creatinine output. What does it mean? According to serum creatinine, it comes in stage 1. Urine output, it comes in stage 2. Then take it as stage 2. Whichever is worse of that. Like that. Okay? Now you see. The perfusion, the heart is there, the kidney on the one side. This is called cardiorenal syndrome. Heart and kidneys are directly connected, operates as a hemodynamic feedback loop. Heart to kidney, impaired cardiac output, heart failure directly causes the venous congestion, reduced arterial blood flow, results in severe renal hypoperfusion and suspected AKI. Kidney to heart. Here, AKI causes systemic volume overload, uremic toxicity, profound neurohormonal activation, ROS is activated, results in accelerated cardiac remodeling, elevated filling pressure, and worsening heart failure. That means heart problem can cause kidney problem, kidney impairment can cause heart failure. When the hypoperfusion can lead to AKI can lead to increased ROS activity and produce heart damage. This is vice versa. This is an infinite loop between heart and the kidney. Cardiorenal syndrome may be a short one. When cardiorenal syndrome means you have to write this, but to heal the kidney, what we should do? We must optimize the physical heart. So if you have to optimize the heart, then the kidney will heal. To heal the heart, we must optimize the kidney. To heal the kidney, we have to optimize the physical heart. Interdependent. Now, you can see the iceberg, only a small amount of AKI is visible. Beyond the creatinine, if you only depend on the creatinine, you will miss a large quantity of AKI. That is this iceberg. The future diagnostic assessment is here. Lacking indicator, serum creatinine, a marker of functional loss, not structural injury. It takes 48 hours to accumulate and reflect a drop in GFR after 48 hours. Before that, a lot of damage is done. It remains entirely blind in the early cellular stress. Novel biomarkers are important now. They can detect the AKI in the first 6 hours or 24 hours itself. NGAL, neutrophil gelatinase associated lipocalin. This is called NGAL is one biomarker. KIM1, kidney injury molecule 1. Cell site arrest markers like TIMP2, IGFBP7. There is a cell replication cycle is arrested at the mitochondrial level. So these are the three types of markers. What are the kidney markers, biomarkers for kidney disease, acute kidney disease? NGAL, KIM1, and then TIMP2, IGFBP7. You should not forget that. Every suspected patient, you must do the markers. Why? Even before the urine output falls, even before the creatinine is elevated, we will see the biomarkers already showing the structural renal damage. Identifying cellular distress hours before functional filtration fails. That way, the iceberg can be avoided. You can diagnose early AKI and more cases can be put on treatment. I hope you got this answer. Did you get it, Sudarshana? So here, you don't depend on the creatinine alone or the urine output alone. You look for the biomarkers. Biomarkers focus on the structural damage. So much so, you can start the treatment early and you are forewarned because the structural damage is early to occur, then the functional impairment. Now, next generation classification, that is your classification. Our classification was pre-renal, renal, post-renal, which is no more tenable. What is the present classification? CUB classification, also called the CUB classification. Integrating the damage biomarkers alongside creatinine and urine output to refine the risk strategy. See, creatinine, that is C0 to C3. 4 stages are there. Creatinine normal, creatinine third stage, C0 to C3. This is according to the KDIGO, International Agency. The second one is urine output, U0 to U3. Again, there are 3 stages. Reflects functional volume regulation based by the KDIGO strategies. B, biomarkers. Only 2 biomarkers negative, biomarker positive. B0, B1. C is creatinine normal, stage 1 creatinine, stage 2 creatinine, stage 3 creatinine. I have told you, less than 2 to 2.9, more than 3 times creatinine, or more than 4 milligrams are the 3 stages. 0 is not. Urine output also I told you 0.5 ml less than 6 hours, 0.5 ml less than 12 hours, 0.3 ml more than 24 hours. U0 is not. U0 to U3. Biomarkers, B0 is negative, B1 is positive. Danger of subclinical AKI. A patient can be CO, C0 and U0. That means there is no functional loss, but B1 positive already covert cellular stress carries significant risk and requires intervention despite normal lab results. You understand? So despite the normal lab results and urine output, biomarkers are positive. You have to start treatment for that patient. Now, etiology equation. I told you susceptibility on one part, exposure on the other part. What are the susceptibilities? Pre-existing CKD. The age is a very important factor for acute and chronic CKD, diabetes mellitus, heart, liver and lung disease, anemia. It is common for hospitalized patients to have multiple overlapping etiologies at once. What are the common susceptibilities? Pre-existing CKD, advancing age, diabetes mellitus, liver, heart and lung disease, anemia. What are the exposures? Sepsis, critical illness, trauma. Somebody has got a very road trauma and tissue injury is there. Lots of dangerous proteins are released into the body. They clog the kidney and produce AKI. Or severe sepsis can lead to hemodynamic changes and also structural damages at the kidney level, or any critical illness. Major surgeries, cardiac surgery, abdominal surgery, tissue handling is there during the surgery, and that can lead to exposure. Nephrotoxic drugs, you should not forget. What are the nephrotoxic drugs? We will show you another slide. Another thing is radio contrast agents. Also, acute kidney injury can be due to radio contrast agent. Volume depletion or circulatory shock due to gastroenteritis or any other volume loss can be the cause. Susceptibility and exposure. So, AKI rarely has a single cause. It manifests when an acute biological sensor strikes a vulnerable patient. Just like for the tree to grow, you must have a proper soil as well as the seed. The seed is the exposure, the soil is the susceptible patients. Soil seed hypothesis. Environmental context, community versus hospital. Is the AKI occurring in the community or is it in a hospitalized patient? That is acquired in a hospitalized patient. Context, majority of the AKIs begin before the admission. Reason, volume depletion, poor water access, gastroenteritis, summer, heat stroke, all those things. Community onset of sepsis like community pneumonia, community acquired pneumonias, tropical infections like malaria, dengue is notorious to cause AKI, and then leptospirosis. Malaria, dengue and leptospirosis you should always exclude when for the community AKI. Toxins, nephrotoxic herbal remedies, snake envenomation is also a cause of acute AKI. Hospitalized develops under medical observation, often iatrogenic. Why? Hospital-acquired sepsis, ICU critical illness, major surgery, especially bypass, cardiopulmonary bypass, medication toxicity, aminoglycosides, vancomycin, etc. These, kanamycin, netilmycin, streptomycin, all these mycins, aminoglycosides, and radio contrast agent given. After that, you get this one. This is the community acquired AKI, hospital acquired AKI. Now, a closer look, high impact critical care etiologies. What are the three important things I will focus? Sepsis and infection. Sepsis is the single most cause in the critically ill, representing more than 50% of the ICU cases. It includes bacterial sepsis, viral, parasitic infections, COVID, malaria, dengue, any one of these. So, whenever AKI is presented, you should rule out all these diseases. Cardiac and vascular surgery, complex insults involving cardiopulmonary bypass causes injury via massive hemodynamic shift, systemic inflammation, mechanical red blood cell damage. This is also mechanical hemolysis, because when you do the surgery or prosthetic valves, there is what is called a sort of hemolytic anemia develops, and this hemolyzed product will interfere with the renal structural proteins. And nephrotoxic medications, 30 to 50% of AKI is due to medicines, aminoglycosides, vancomycin, NSAIDs, and remember, left and right we are using proton pump inhibitors. They can be a cause for acute kidney injury. Proton pump inhibitor, not very common, but they can be there. Done. So earlier, nowadays, we are classifying as pre-renal, intrarenal, post-renal, 3 buckets we used to keep like that. It's not like that now. Now, hemodynamic, inflammation, microvascular thrombosis, AT, that is acute tubular toxicity. Sepsis paradox. Historically, sepsis-associated AKI was thought to be pre-renal. Whenever you ask anybody what is sepsis produces hypotension, that produces AKI. It's not like that. Now, sepsis, in addition to hypotension, AKI develops in the septic patient because of hemodynamic instability, even in the presence of increased or normal blood flow. So, the modern pathogenesis is a web of systemic, inflammatory, and toxic pathways. Hemodynamic, inflammatory, toxic pathways, and microvascular thrombosis together can produce this pathogenesis. Now, pathway 1, sepsis and immune response. What is the first one? Pathogen invasion that triggers massive release of pathogen-associated molecules. Pathogen-associated molecules are the PAMPs, metalloproteins, pathogen-associated metalloproteins, and DAMPs, PAMPs and DAMPs. DAMPs means damage-associated molecular proteins. Pathogen-associated molecular proteins, damage-associated molecular proteins are released into the bloodstream. Step 2, what happens? These are proteins. These molecular proteins are filtered through the glomerular membrane and in the peritubular capillaries. And step 3, they bind to the toll receptors there. They are called PAMPs and DAMPs, bind to the toll-like receptors TLR2 and TLR4 directly on the surface of the PCT and produce a acute tubular necrosis. And finally, cellular crisis. This triggers extreme oxidative stress, reactive oxygen species are released, and mitochondrial injury is there, leading to cellular shutdown. Now, very clearly we know these are the 4 steps of cellular injury and the pathogens. Step 1, the infecting agent or the exposure produces massive release of PAMPs and DAMPs. PAMPs and DAMPs are pathogen-associated and then damage-associated molecular. They being proteins, they get filtered at the glomerulus. They clog the glomerulus. They also infect are permeating into the tubules. Then they let them go, but they don't keep quiet. They go and bind to the receptors there. These are the TLR2 and TLR4 toll-like receptors are there in the PCT, and PCT is shattered and damaged. Then what happens? The PCT is opened up, the cellular cell of the PCT, and mitochondria are destroyed, leading to cellular shutdown through oxidative stress, reactive oxygen species production. These are the 4 steps in the pathogenesis of acute tubular or acute kidney injury. Now you see the red zone on both the sides and the euvolemic zone. So on the left side, AKI complication severity are maximum in the restrictive zone, maximum in the liberal zone. And the complications are minimum in the fluid balance zone. What is the fluid balance zone? Euvolemic sweet spot, optimized cardiac output. Either cardiac output is not reduced or heart is not overwhelmed by fluid overload. In such a situation, the fluid balance is maintained, AKI complications are minimal. Now, you go to this side, hypotension is there, reduced forward flow, organ hypoperfusion, cellular ischemia, that is the negative fluid balance there, that produces AKI. The other side, go to venous congestion, intra-abdominal hypertension, high back pressures from right heart, cardiorenal syndrome, that is the liver positive side. The negative fluid balance, positive fluid balance, both have got a role in the complications and the severity of the AKI. Kidney perfusion is deeply sensitive to the fluid status. That is why even when you are evaluating hyponatremia, what you are doing, is it hypovolemic, is it normovolemic, is it euvolemic, you are looking at that. Here also, like that, you have to look at the volume status. Is my patient hypovolemic and hypoperfusion? Is my patient non-euvolemic or is overloaded, fluid overloaded? Treatment differs. Fluid overload, you have to use diuretic. Hypoperfusion, you have to infuse fluid. So the treatment differs. So you have to measure the volume status. Pathogenesis 3. Two levels I have shown you. The first level is at the cellular level, molecular level. The second level is at the hemodynamic level. Okay, the euchre. And the third level is nephrotoxins and the endogenous toxins. Direct tubular toxicity, accumulation of toxins in the PCT causing direct cell death like amyloglycosides, vancomycin, heavy metals like that. Acute interstitial nephritis, AIN, immune-mediated allergic inflammation of the interstitium, beta-lactam antibiotics, PPIs, NSAIDs cause AIN. That is acute. Now you see, back here. Now, in the pathogenesis, there are three levels, I said. First level is the sepsis. First level is the sepsis-related thing. And then the hypoperfusion and all. That is the first level. Sepsis and immune response, 4 levels are there. And next one is the U curve, that is the hemodynamic curve, where you have hypoperfusion, euvolemia, and hypovolemia. And then you have got the nephrotoxins, direct tubular toxicity, acute interstitial nephritis, endogenous toxins, crystal nephropathy, all play a part. Now, you see here, the synthesis. Now we have to converge all the pathways of injury into one. What is that? Regardless of the original insult, AKI pathogenesis ultimately converges on the renal tubular epithelial cell. Somebody asked, what is it that is damaged in AKI? It is not the glomerulus. It is the renal tubular PCT epithelial cell. The damage is in the proximal convoluted tubule. Exposures, sepsis, inflammation, heart failure, congestion, hypoperfusion, drug toxicity, trauma, endogenous. All lead to cellular reality. That is what happened: mitochondrial dysfunction, oxidative stress, cell cycle arrest. How do I diagnose it? Diagnosis by functional loss, serum creatinine, falling urine output, take time, 48 hours to develop. Whereas if you use the biomarkers like TIMP2, IGSBP7, NGAL, early warning signals. Now you got it. How you have to go about it. So diagnosis is by the functional loss, structural loss. How do I identify structural loss? By the biomarker. Now, so paradigm in AKI, diagnosis, 3-axis staging, modern differential diagnosis, clinical implementation, blueprint. 1. Define and detect and diagnose, quantify the grading, differentiate the etiology. Integrating the functional criteria with new structural biomarkers. Quantify the grading, U, C, UB, C0 to C3, U0 to U3, B1 and differentiate multimodal workups, replacing outdated method of classifying as pre-renal, post-renal like that. From reactive numbers to proactive precision. 2026 guidelines redefine AKI as a highly measurable, multidimensional clinical event. Okay. Now, functional criteria, structural criteria. Serum creatinine more than 0.3 in 48 hours, more than that is 1.5 times baseline 7 days. Urine output less than 0.5 per kilogram, more than 6 hours. Cystatin C also 1.5 times. Structural criteria, biomarkers, elevation of validated biomarkers, the kidney damage, which we have seen already. Dashboard alert. The first time structural damage alone can formally define an AKI episode even before the functional decline is visible. What is that? Serum creatinine is normal, urine output is normal, structural damage biomarkers are positive, means patient is already in AKI. Okay. Now there are 4 boxes now. Subclinical AKI, damage present, no clinical decline. Established AKI, decline is there, damage also is there. And the hemodynamic decline is there, but there are no structural biomarkers are negative. And normal, no decline, no damage. So 4 boxes. The gray box is the no decline in the renal function or cardiac output or no increase in the creatinine, no structural damage, no damage is done. Second one is damage is evident, but then no functional decline. Third one is there is both functional decline and as well as damage is there. Fourth one is there is no damage, biomarkers are negative, but the fellow has got functional decline. These are the four important things. Diagnostic blind spot is that yellow one is the blind spot, because if you look at only creatinine and urine output, you will be missing the subclinical AKI. That should not be done. Now you see the three curves. The yellow one, stress markers, how many time from insult, 0 to 48 hours. Stress markers are the first to appear. What are they? TIMP2, IGSBP7. They give the alarm bell, G1 cell cycle arrest. At that G1 level, cell cycle arrest because of mitochondrial failure. Number two, damage biomarkers which come late, around 2 hours and last for longer time. These are NGAL, LFAB. These are called injury confirmation. And finally, functional markers are your serum creatinine and falling urine out. 3 levels we can classify: stress markers, damage marker, functional markers. Stress markers are early to appear. They are TIMP, IGFBP7. They give the alarm bell. Damage markers, NGAL, LFAB, FABP are the injury confirmation. And of course, renal creatinine rise and then urine output falling is the trailing indicator. Now, diagnostic matrix. TIMP, IGSP7, G1 cell cycle arrest, diagnostic cutoff more than 0.3, clinical condition, lower specificity and chronic inflammation. NGL, distal tubular damage, cutoff is more than 0.1, often elevated in general sepsis or UTI. LFAB, proximal tubular antioxidant, lower accuracy in late stage representation. Cystatin C, GFR functional alternative, more than 1.5 times 60 cutoff, less accurate with high dose corticosteroids. These are some of the limitations of this test. Now you see the 3 pillars: the C pillar, the U pillar, and the B pillar. In the C pillar, how many you have? C0, C1, C2, and C3. And the U pillar, how many you have? U0, U1, U2, U3. Why we have put like that? Creatinine is rising, urine output is falling. That's why C0 is we have put below and C3 above. Whereas for the urine, normal is above, decreasing is in the bottom. That's why biomarkers are 0 is no biomarker positive, B1 is biomarker positive. It's called the COB axis. Now, constructing the COB axis. Creatinine, C axis. Urine output, U axis. As already told, C1, C2 and C3, U1, U2 and U3. Already I defined those values for you. Now, you have the biomarkers, binary mode, B0, negative, B1 is positive, structural damage biomarker below the clinical threshold, elevated biomarkers and damage like TMP12 or IGFBP7. This is very important. Now, differential diagnosis workup. See, 6 core determinants are there. So, differential diagnosis workup, look at the fluid status. Avoid assuming routine dehydration. Don't assume rehydration. Why? Sometimes fluid overload can cause AKI. Well, you measure the fluid status. Infections. Sepsis remains the leading cause. Urine analysis. Identify the active sediment. Granular case, acute tubular injury. Hemodynamics. Assess the cardiac output and perfusion. Medications. Review. And then NSAIDs, ACE inhibitors, ARBs, contrast dyes, industrial toxins. Imaging to rule out post-renal obstruction. Do an ultrasound to do any post-renal obstruction like a stone or a stricture or a malignancy or anything. Do not treat every AKI as simple dehydration. Because AKI means no, the patient is vomiting, hypovolemia, start giving fluids, patient will die. Systemic 6-domain general workup narrows the differential diagnosis. What are the 6 domain? Fluid status, infection, urine analysis, hemodynamics, medications and toxins, and image for the post-renal workup. Now, outdated paradigm, over-reliance on fractional excretion of sodium, FENA, heavily confounded by diuretics, CKD, aging. KDIOG 26 reality, strong recommendation against isolated use of FENA, fractional excretion of sodium or urea. Modern approach, combine urine microscopy with structural biomarkers and fluid challenge. Exception, FENA remains a highly useful agent specifically for evaluating hepatorenal syndrome versus acute tubular injury in cirrhosis patients. If the patient is a cirrhotic patient, there could be hepatorenal syndrome, not cardiorenal syndrome. In such a situation, FENA will be, or FE urea can be useful. FE is fractional excretion. So this is a modern guideline compared to previous guideline. Now you see the critical role of focus in AKI, renal ultrasound. Okay, rapidly rule out post-renal injury and tract obstruction. Kidney Doppler, RRI, measures renal restrictive index to assess the risk of AKI progression and severity in clinically ill patients. Then the venous access ultrasound evaluates the inferior vena cava and a hepatoportal vein differentiates the venous congestion from true hypovolemic volume depletion. Focus differentiates volume responsive AKI from congestive or intrinsic AKI in real time bedside. What is focus? It is an ultrasound, renal ultrasound, kidney Doppler, and venous access. All three together comes under the focus. And this will tell you whether the patient is volume responsive, that means you have to give fluid, or is congested, we have to stop fluid, or intrinsic AKI, euvolemic. This is decided by the radiologist. Now, bridging the gap. Acute kidney disease, 0 to 7 days AKI, 7 to 90 days AKD, and more than 90 days it is CKD. Acute insult, second one is critical recovery for or progression window defined as GFR less than 60, structural damage persisting up to 3 months. Permanent CKD where we evaluate as per the previous class. Dashboard, alert. Crucial update, AKD can be diagnosed entirely without a prior recognized AKI episode. Patient may not have an acute AKI presence. Earlier, AKD can be coming directly. It bridges the gap where patients are frequently lost for follow. Now, CAMS and watch me. What is CAMS? Kidney function checks, assess every 3 months. Advocacy, access to education and psychosocial support. M, medication, safely restart RAS inhibitors and SGLT2. Pressure, strict BP and volume control. Sick day protocols, guidance for acute illness. KAMPS, K, kidney function check, A, advocacy for education, M, medication, P, pressure, S, sick day protocol. Watch me, weight assessment, access care, teaching, clearance, hypotension management, medications, and electrolytes. Okay, now, what do I do? Screen new SIRS, that is an acutely ill patient, not just for the Qs of OSCO. Any acutely ill patient, screen for the AKI. Diagnose, check creatinine, urine output, and structural biomarkers. Then stage it based on CEUB axes. 4. Differentiate focus, whether it is hypovolemic or hypervolemic or normovolemic based on urine sediment, contextual history, limited use of FENA, and doing the ultras. Transition, monitor actively for AKD between 7 and 90. Don't treat AKI and then leave it, because patient can go into AKD and then you have to follow him up. And discharge from AKI is only a continuum there. That is follow-up 7 to 90 days is crucial. KDIGO 26 framework transforms AKI from an isolated laboratory abnormality into a precision managed and then continuous clinical trajectory. Acute, what are the treatments we have? KDIGO 26 guidelines and update, management, prognosis, and follow-up. It is a continuum. Previous days, what you used to do, 2012, isolated hospital event, creatinine and urea, creatinine is elevated, urine output is decreased, reactive, treat the complication, ad hoc or absent, follow-up, it's not done, usually absent. Today, AKI, AKD, CKD is a continuum. Subclinical injury and biomarker guided precision. Proactive nephroprotective bundles and stewardship. structured surveillance. Discharge is only a transition. Dischargement doesn't mean that the patient is cured. He can go into AKD, from there he can go into CKD. Okay, now the core principles of clinical management. Number 1, hemodynamic optimization. 2, source control. 3, nephrotoxic cessation. 4, metabolic management. Hemodynamic, restore intravascular volume, support perfusion pressure, monitor fluid balance obsessively to avoid deleterious fluid overload. You should avoid overload, at the same time hypoperfusion must be corrected. Step 2, is aggressively treat underlying infection, that is sepsis, reverse mechanical obstructions, optimize cardiac output. Step 3, nephrotoxins. NSAIDs, temporarily you pause ACE inhibitors, CRBs. Avoid contrast dose, adjusting dose for any renally cleared medicines. If the clearance is by the kidney, such medicines you have to reduce. Correct severe hyperkalemia, manage metabolic acidosis, and ensure adequate nutritional support during this catabolic phase. Those are the 4 steps of core clinical management: hemodynamic, source control of infection and exposure, nephrotoxin cessation, metabolic control. Now, you see the time, navigating the clinical continuum, time 0 to 48 hours, hemodynamic resuscitation, fluid management, vasopressor escalation will be the thing. Phase 2, stabilization stewardship, 2 to 7, nephrotoxic stewardship, RRT initiation, renal replacement therapy, nephroprotective bundle. Phase 3, long-term surveillance, 90 days and beyond, assessing prognostic thresholds, structured follow-up, camps, watch me has to be used in that. Now, we have optimizing intravascular volume, fluid resuscitation method. Now, target to administer at least 30 ml per kilogram of IV crystalloid in the first 3 hours. Sepsis-induced hypoperfusion. Use dynamic measures like SV, SVV, PVV. This is the historic volume and then the pressure gradients to guide ongoing resuscitation. What do I use? Buffered crystalloids. KDIGO 2026 says use for standard volume expansion in the absent traumatic brain injury. 0.9% specifically preferred our hypotonic solutions for patients with traumatic brain injury. No traumatic brain injury, use crystalloid. Traumatic brain injury, use 0.9%. Colloids and albumin only suggested against an initial standalone therapy, but can supplement patients requiring massive crystalloid volumes. That is, gross hypoperfusion is there, then you can use albumin, or colloids. And starches and gelatin, high risk of harm and further renal insult, explicitly advised against in the resuscitation. Crystalloids are the choice. Brain damage is there, then use 0.9% saline. Colloids and albumin, if it cannot be controlled by crystalloids, don't use starch and gelatin. Okay, step 1, norepinephrine. Step 2, vasopressin. Step 3, pressor. This is called vasopressor escalation, a staircase of vasopressor escalation. What is the drug of choice? Norepinephrine, not epinephrine, not dopamine. Recommended over dopamine, epinephrine or vasopressin alone, first line agent in hypovolemia, hypoperfusion, low blood pressure in AKI. For pressure escalation, norepinephrine is the first line of choice. Start peripherally if central access is delayed or rapid to restore the mean arterial pressure. First escalation, that vasopressin. Add to escalating dose of norepinephrine when initial monotherapy is insufficient. Use vasopressin. Then refractory shock. Add if mean arterial pressure levels remain inadequate despite combined norepinephrine, vasopressin, then you can use epinephrine. Note on hepatorenal syndrome, if the patient is having liver disease and renal syndrome in AKI, terlipressin or norepinephrine are preferred. Midodrine and octreotide are as backup. Terlipressin is suggested as an edge against a standard septic shock. These are the pressors. What is the first pressor? Norepinephrine. Not dopamine, not epinephrine, not vasopressin. Second level escalation, vasopressin. Third level, epinephrine. And hepatorenal syndrome, terlipressin or not. Now, deploying the nephrotoxic bundle. So we have got, you see, we are systematically going. First, we are going about the intravascular volume. Then we have gone about the pressure escalation. Now we are thinking about the nephrotoxic. Hemodynamics, volume control, glycemic control, nephrotoxin, and diagnostic accuracy using the biomarkers. Optimize status via appropriate fluid therapy, vasopressor, iron. Second level volume control, diuretics are now formally suggested for managing clinical volume overload. You can use diuretics. Volume overload is the cause of the AKI. Glycemic control, how do I know it's volume overload or volume deficient? By doing the focus, by doing the ultrasound of the 3 levels there. So glycemic control, relax the glucose target. Another important thing is, earlier we used to say keep the sugar below 140. Now the change is keep it between 140 and 180. Be a little liberal on the glycemic control. Don't be too rigid on the glycemic. Nephrotoxic stewardship, discontinue nephrotoxic medications. Immediately adopt therapeutic drug dosing to altered AKI kinetics. If the kidney drug is being excreted to the kidney, you reduce the dose to half or even 1/4. Diagnostics, discontinue unnecessary contrast, avoid acetylcysteine. Sometimes they have recommended earlier acetylcysteine is being used. Now that is removed from the treatment. Evaluate etiology via urine microscopy and structural biomarkers. Now, renal transplant therapy, RRT. What did we do? First, we managed the body. Then we increased the pressure. And third, we took care about the renal nephrotoxic drug. Now, can we do the RRT in a selected cases where renal replacement therapy is required beyond the biochemical trigger? Patient's clinical status, volume, hemodynamic stability, metabolic signs, all are important. Initiation is clinical, not chemical. Initiation of RRT is not based on creatinine. It is based on the clinical judgment. Should not only rely on urea and creatinine thresholds, trigger RRT based on individualized clinical status, volume overload, severity, metabolic derangement, failure of medical management. For example, diuretics. So RRT will be required like that. Initiation is clinical and not chemical. Lab values, secondary. Patient clinical status, very important. That's why the balance is in favor of clinical status and not on the lab values. 2. Guided by patient. Hemodynamic stability, available medical and nursing expertise. Finally, resources rather than a universally mandated modality. Discontinuation and transition. Assess native kidney recovery continuously. Survivors with residual renal impairment must be integrated into CKD management. And this is a continuum. Now, to come to the urgent indications for RRT. What are the urgent indications of RRT in a patient of AKI? AEIOU. The ovals. A. Acidosis. Severe refractory metabolic acidosis that does not respond to medical therapy. E. Severe refractory hyperkalemia posing immediate arrhythmogenic risk. That is hyperkalemia is electrolyte. I. Intoxications. Circulation of dialyzable toxins like lithium, ethylene glycol or salicylates are there. Then you dialyze and remove the toxin. That is I. O. Overload. Refractory volume overload not responding to diuretics, particularly when presenting as a life-threatening pulmonary edema. You do RR. And finally, uremia. Severe uremic complications, uremic encephalopathy, uremic pericarditis, unexplained bleeding diathesis due to procoagulant, pro-bleeding state, hemorrhagic state because of uremia. AEI, acidosis, electrolyte abnormality, particularly hyperkalemia, I intoxications, particularly lithium and ethylene glycol, salicylates, O volume overload, U uremic complications. These are the indications for RRT. Now, you see, fluid resuscitation logic. Buffered crystalloids are the treatment of choice. Only when the patient has got brain injury, 0.9% saline. Hemodynamic perfusion targets, individualized targets, when to what is the cutoff? Mean arterial pressure more than 65. Individualize the targets, maintain higher perfusion pressure for chronic hypertension, and then avoid excessive vasopressor toxicity in chronic hypotension. And nephrotoxic stewardship, sick day protocols. What are the things I stop? Sulfonylureas, ACE inhibitors, ARBs, diuretics, metformin, NSAIDs, SGLT inhibitors. Until the patient recovers, withhold these drugs or reduce these drugs. Relaxed glycemic thresholds, don't be too vigorous to reduce the sugars below 140. Earlier it was 110 to 149. Today it is 140 to 180. Intensive insulin therapy is no longer favored to prevent AKI in critically ill patients. This is called the optimization and stewardship. As far as the fluids are concerned, I give crystalloids as first preference, not 0.9% saline. And as far as hemodynamic perfusion is concerned, MAP should be at 65. And nephrotoxins should be avoided. Glycemic controls are relaxed. Okay. Now you see advanced rescue escalation and RRT off ramp, that is pharmacological fluid rescue. You tried that, and then RRT paradigm shift phase 2, discontinuation gate. Now what do you do? Targeted action table, HRS AKI, hemolytic uremic syndrome AKI, and then heart hepatorenal syndrome AKI. HRS is hepatorenal syndrome AKI, terlipressin or norepinephrine, midodrine, octreotide, wake-up. Tumor lysis syndrome, tresbutylicase is the drug of choice. Volume overload, intermittent loop diuretics. Early extracorporeal removal is not done now. Now, clinical tolerance window, deferred strategy, delayed RRT initiation until absolute life-threatening refractory thresholds are crossed. Modify modality, if hemodynamic instability mechanism necessitates RRT, default to CRRT with regional citrate anticoagulation. Okay? And data gate, threshold metrics or stop RRT. Clearance more than 20 is creatinine, stop RRT. Volume more than 450 ml output is coming in the urine, stop RRT. Volume with diuretics more than 2.3 liters is excreting, stop RRT. This is how the modern management is tailored, very structurally, very. Finally, you see prognostic threshold, transient versus persistent AKI, transient AKI less than 48, persistent 2 to 7 days, trajectory, correction of kidney perfusion, rapidly restores the function, complete sustained reversal within the window is associated with significantly better long term. So kidney function and time you see. So initially the transient and find the A is the transient curve, B below is the persistent, that is 2 to 3 days, and failure to reverse within 24 hours marks the transition into acute kidney disease. From AKI, he has shifted to AKD, associated with a dramatically higher 20-year incidence of CKD. So, very important that it is a continuum. AKI is not alone. AKI, AKD, CKD. Now, dual testing imperative, that is 90 days. What you have to do? KDIGO guidelines mandate that AKI, AKD survivors be evaluated 3 months post-injury. Every patient of AKI must report back after 90 days. This is the critical window to capture whether they have progressed on to CKD. Dual testing imperative, assess function, EGFR, creatinine, cystatin. Assess damage, use urine albumin creatinine ratio, urine protein creatinine. 90 days. Why do you have 90? Both reduce EGFR and the presence of albuminuria. 3 months are highly predictive of subsequent irreversible CKD. If it were to reverse, they will become normal in 3 months. If the proteinuria is persisting or creatinine is elevated beyond 90 days, they are going to become CKD patients. It represents the clinical deadline to formalize a long-term nephrology care plan. Okay, now, we already showed CAMPS and watch me. What is CAMPS? Kidney function check, A advocacy, M medication, P pressure, S sick day protocol. Watch me, weight assessment, access for the dialysis, teaching the patient education, clearance, monitor residual kidney function, and hemodynamics, medications, and electrolytes. It's called Watch Me. So now pediatric imperative, the pediatric nephrotoxic stewardship, vulnerability factor, pediatric and neonatal ICU populations face magnified CKD risks due to the compounded presence of nephrotoxic antibiotics, NSAIDs, and vasopressors. In our cohort, every patient CKD at 3 to 5 years post AKI had evidence of it in at least one of their first year follow-up visits. That means these fellows have to be followed clearly. Ninja protocol, nephrotoxic injury negated by just-in-time action. That's called Ninja protocol. Systematic monitoring of the daily nephrotoxic exposure limits of injury, early detection, blood pressure monitoring, limiting subsequent nephrotoxins, subsequently mitigating progression to lifelong CKD. Now, CKD drives AKI, AKI drives CKD. AKI is not different from CKD. CKI drives AKD, AKD to AKI to AKD, AKD to CKD. And one has got CKD, acute injuries can follow. Ultimate synthesis, preventing acute insults in ICU and meticulously managing follow-up for 90 days are two sides of exactly the same coin in preventing chronic kidney failure. 2026 guidelines definitely establish that acute kidney injury, chronic failure are not separate diseases, but a continuous bidirectional cycle. Now, precision resuscitation, time is that issue, continuity is mandatory. Transition from reactive fluid overload to targeted dynamic volume optimization. Using balanced crystalloids early, stepwise vasopressor escalation. Time is tissue, prioritize every nephroprotective bundle to achieve transient AKI and terminate it before 48 hours, rather than allowing it to go beyond 2 days, where the persistent damage comes. Finally, continuity is mandatory. Discharge is only a transition. It is not an endpoint. Implement structured surveillance with KAMPS. Watch Me are the acronyms, and mandatory 90-day dual testing to intercept the AKI to CKD pipeline. That is, everybody should be tested at 90 days. Dual testing, but one is the creatinine, the other is urine and cystatin. Now, this ends the presentation. Wisdom in stillness is jnana. True healing requires absolute mastery over the intricate mechanics of physical body, paired with the compassion to nurture the boundless depth of the human spirit. Every patient is a human being, and you must nurture the compassion to prevent AKI going on to AKD, going on to CKD. And this is an eye-opener, this lecture. All of us have to follow this. With this, we'll end this presentation.